Okay. So this is today's topic. So next 15-20 minutes we are going to think and discuss about the what are the options of invasive interventions in the management of osteoarthritis knee and osteoarthritis knee. All interventions can be used for arthritis in other joints also, but knee being most common in our OPD. That's why I have kept the topic osteoarthritis of the knee. The all the minimally invasive interventions that are available are mainly a bridge between a conservative management and the surgical options. So it is just a missing link which was there, and lot of research and study is happening in the world of management of osteoarthritis knee. Rather, even in the medical world, everything is now shifting from open surgery to minimally invasive surgeries. So, minimally invasive interventions is the need of the hour and the latest trend. So, what are the options that one can use, and what are the benefits, and what is the outcome, and what are the standard recommendations are there that I will be discussing today in next 15 minutes by the time you finish your tea. So most common, most old is this intra-articular steroid injection or the corticosteroid injections. How it works: suppresses the inflammatory mediators. There is one saying that whether the osteoarthritis is an inflammatory disease or a non-inflammatory disease, it is a non-inflammatory disease, but there is inflammation in the latter stages, and that's why this degenerative becomes an inflammatory mediators that is around it, and henceforth the steroid has a good role. But the thing with the any intra-articular steroid is its short-term efficacy, and it leads to the risk of accelerated osteoarthritis. When I say accelerated osteoarthritis, means because of the steroid, there will be, although it is a progressive itself a progressive disease, this may get um, accelerated because of the bone loss. That is because of the direct action of the steroid. So earlier it was a strong recommendation. Now, as newer modalities are coming up, now it has been most of the guidelines have put it from strong to moderate, downgraded from strong to moderate recommendation. Now, how long to give and what is the duration of its activity? Mostly in clinical practice, you will find that it is the 2 to 3 weeks that it is effective. But 1 month, 1.5 months after that, patient will again turn up to you. I was pain free for 1.5 months. Now again, I am having the problem. So you have to think on that pattern. Patients will keep coming and troubling you, just like your girlfriend or a boyfriend. Boyfriends are less. And what is the duration of action? How long this works, and should be the interval between two steroid injection, especially prior to the surgery. If surgery is planned, it is 3 months. Minimum 3 months of gap is needed before the surgery is planned, because again, bone loss, muscle loss, and everything will be there that will be contributing to it. Now, again, another thing is intra-articular hyaluronic acid injection. It is commonly prescribed in OPDs. It has a role. It acts as a lubricating agent. It is a counterproductive, anti-inflammatory, and it is a vasco-supplementation. Now, because of this viscous supplementation, it works like a shock absorber that is there in our bike or our car or even our cycle. And that shock absorber part is very important because there is degradation of the synovial membrane, leading to loss of this synovial fluid, and that leads to the pain. And that is one of the reasons. Because of this viscous supplementation, it reduces the pain and stiffness, and also it has been found to increase the knee functionality. However, these improvements are not clinically substantial enough to be a viable treatment for patient of knee osteoarthritis. When I'm saying viable treatment for knee osteoarthritis, I mean to say that that is only a treatment option or things will get cured. No, not possible. Some part of it has been so sorted out. The reason I have already explained in the previous classes, that there is associated sarcopenia, there is a muscle loss, there is a tendon loss. That repair is not there. Only supplementing with the synovial fluid won't be enough to manage things with the intraarticular hyaluronic acid. That's why all those patients who need intraarticular hyaluronic acid injections, they have to have its efficacy from 3 months to 6 months. In my clinical practice, whatever I see, patient will turn and say that injection worked for 6 months, that worked for 3 4 months. After that, it has worsened. So artificial supplementation is there now. This hyaluronic acid and all has its own different mm, functionalities and types that are available in the market or in the research has come up. So everything needs to be assessed and reassessed, and it is never a treatment option for any. And not only the intra-articular hyaluronic acid injection, all minimal invasive uh, interventions that we are doing is not a viable treatment for patients. Not only this, everything, and you will come to know about it in other slides. Now, PRP, yes, definitely PRP is a new darling in the osteoarthritis research, and it has its own mechanism of action where it works by inhibiting the osteophyte formation and reduces the inflammation. That this point reduces the inflammation is very important because the mechanism of PRP starts with increasing the inflammation, and that increased inflammation leads to promote the cartilage repair. So whenever you are giving intra-articular PRP injection or prolotherapy, then make sure that patient have you have to caution them that there is going to be inflammation, there is going to be tenderness for first 2 3 days. After that, it will subside on its own. So no, there may be an increase in pain as well. This pain increment will be there at the time of pain will be there when you are inserting the PRP injection, when you are giving the intraarticular injection. At that point of time, all of a sudden, patient will tell you that there is increased pain. One of the reasons for this increased pain is that everything is suppressed at that point of time, meniscus and everything is dehydrated, and that all of a sudden will start expanding. That will cause the increase in pain. And also, the PRP, the issue is regarding whether it is a poor or a rich. Then poor or a rich, it means when it is a poor leukocyte or rich in leukocyte, it all depends on the composition of the PRP, how you are making, which machine you are taking, how whether you are taking the superficial layer only or the buffy layers, white coat, how you are separating. Everything will lead to the outcome of your patient, and that's why there is no consensus what should be the composition. It's from uh, 3 lakh per mm cube to 15 lakh per mm cube. There is a wide variation, and the researches are limited for the meta-analysis, or the RCTs are very limited in its role. And this is one thing that we have to keep in mind: how you are keeping, how you are giving, how you are separating, and this also matters a lot. Now, whenever you are giving, along with the on the same principles of the platelet-rich plasma acts this prolotherapy, dextrose prolotherapy that is being given, or even normal saline that has shown some good results in some of the studies. Dextrose again works like inflammation concentration. What concentration of dextrose should be used? It is again variable. The concentration of dextrose varies from 5% to 25 30%, even up to 50%. Some studies have shown. Again, how much to give, whether a local anesthesia has to be given or not, bupivacaine to be added or not, all these things is a point of discussion. So keep this thing in mind, that whenever you are giving any regenerative therapy, there is always a chance of inflammation and or any other before the cartilage repair starts. So what is the technique and approach to intraarticular injections? Intra-articular, somewhere you have to reach the joint, That's it. You can do things differently. Now it can be lateral superopatellar, superolateral patellar, lateral mid patellar, anterolateral joint line, infrapatellar, superomedial, medial mid patellar, anterior medial joint. 8, 9, 10 types of are there. It all depends on the anatomy of the knee at the time when you are doing intervention. First thing, interventionist confidence in the approach, and accordingly you can manage that. For example, I used to give superolateral patellar approach was my common approach when I used to give it the USG guided. Nowadays whenever I am giving blindly, I do prefer to go for uh, intrapatellar or anteromedial joint line. So whatever is your level of comfort, you have to make sure it is. You can go give it to USG guided, or you can give it C-arm guided fluoroscopy, and there are other techniques also. Commonly, I have you tried both, and both works well. Even remember one thing: even if you don't have these machines, you can go for intraarticular injections of the knee and soldier with anatomical landmarks. It will has more or less shown similar results. It is only on the level of your confidence, how you are doing it, and how you are performing the procedures. Now along with this, these are the traditional things that has been in use. A lot of research is happening. There are other things that are minimal invasive that is under discussion. One is the genicular artery embolization. So what happens in due course of time with the osteoarthritis? There will be hypervascularization of the regions around it, the knee. That is because of the tenderness or because of the this neovascularization. And patients who are poor surgical candidates for the TKA because of any reason, or patients who prefer non-surgical management, they are fit for undergoing genicular artery embolization. And it is a new therapy. No such standard recommendation or guideline is available which patient to do, which patient not to do. Whatever clinical experience I have, mainly it has a limited role in grade 4. Outcome is mixed. Sometimes you will get a very good result, sometimes you won't. The one of the reason is anatomy is not going to change. Anatomy, bony anatomy remains the same. Only is hypervascularized region, whatever is there, that gets embolized. So outcome will be mixed. Grade 2, grade 3, yes, moderate. It has shown good results, especially for the pain relief. So these are the things to be taken care of. One more thing, that is the genicular nerve ablation, and again the indications are same as that of the genicular artery embolization. Moderate to severe osteoarthritis is there. Poor surgical candidate, fails conservative management, or failed surgery as well. Genicular nerve ablation is done. Again, no specific recommendation is there which patient to do or which patient not to do. Now, whenever you are giving a nerve ablation or radio frequency RF ablation, the only thing benefit is patient will be pain free, and of that too for a longer duration compared to the nerve block that you are giving with steroids or steroid mixed with local anesthesia. So up to 6 months, patients have a good result. Then again, you can do it if patient is not willing to undergo surgery. At least you can give a good pain relief, and along with it, you can start the rehabilitation plan. Because with the one of the biggest hurdle within the rehabilitation plan is the pain management. So genicular nerve ablation again has a good result to show. And one thing, genicular nerve cryoneurolysis, it is a less painful compared to the earlier, even during and after the procedure. When you are giving this genicular nerve ablation, it is very painful. So simultaneously, we have to give the local anesthesia at that point of time, because patient will cry out of it when a nerve ablation is being done. So compared to that, nerve ablation, cryoneurolysis is comparatively less painful, and those patients who cannot tolerate other modalities, it can be tried. And with because of the cryoneurolysis, larger zone of ablation is achieved, and it can cover the diverse location of the genicular nerves in the anterior posterior axis on the basis. Only thing with cryoneurolysis is only three nerves can be it is mostly with the same as the radio frequency ablation. It is the superomedial, inferomedial, and superolateral genicular nerves are tried. Inferolateral, as you all know, fibular nerve is sitting out there, and we don't want to trouble it. And one of the problem with the genicular nerve cryoneurolysis is the cost. It is very costly. Instruments are costly and are not easily available or accessible. Most of the places people are doing on a rented thing, and same applies for the genital nerve ablations. So, message to OPD: traditional treatment methods offer a short-term relief. New methods have shown potential for more effective and longer-lasting outcomes, but lot of research is needed. Which to do, when to do, what should be the guideline, when it is indicated, when it is not indicated, and what are the side effects. With every minimal invasive technique that we are doing, whether it is the intra-articular steroid to the nerve ablation, as we are breaching the skin, there will be the side effect because of the breach of the skin, and those infection, inflammation, all these risks are there. Pain will be definitely there because the skin is damaged. So make sure that things are sterile and you don't end up putting any infection into the joint anywhere in the body for the management of osteoarthritis. That's all for the day. Hope you all had your good tea. If there is any question, please feel free to. Okay, Dr. Ishita, your thesis topic is bioviscous in ONE. So whenever you are giving any biovisc or any thing, you have to always compare with it. It is supposed to be a comparative STD, and then sample size will definitely matter in those patients. So when you are doing it, compare with it outcome, and those outcome will always be a multifactorial. So all those factors has to be taken care of. For example, multifactorial, when I say what about the comorbidities, what about the obesity, diabetes, and all these things, and what is the lifestyle of the okay, that's a good topic. And inflammatory markers, it's a good topic to try. Conventional treatment means what? Invasive or non-invasive? Okay, that's good. It non-invasive. Okay, that's good. Good topic to plan because this is the latest area in which the people are doing a lot of research, and IL-6, whether we can work something on it on this basis only. Even DMARDs and all has been tried, and inflammatory markers definitely has a role to play because although it is a non-inflammatory disease, but there is a presence of inflammation. That's a good topic and interesting topic, Dr. Ishita, and it will be worth hearing you at some point of time, or you can discuss your topic if you wish on my personal message also, and will be interesting to see the result and the outcome. Okay, any other question or any other suggestion? Oh, 120 sample size. It's a good size. Although most elderly, every household has a patient. It is definitely with such a big sample size. So 60 each will be there. Definitely, it will show a good result and outcome. So it is going to be 30 each. Sorry, 60. Definitely 60. That's good. That's great. That's great. If you need any help, you can contact me. No issues, and I can make sure it will be your study only. No breach of trust. Are you coming for this OR? There is a association called Society of Osteoarthritis Research. You should join that if there are a lot of research activities happening, meetings, webinars, and all. Okay, you can DM me. I hope you have my number. Is there any radio limit? Is there any time limit for radio frequency ablation in bilateral ONE between right genicular ablation and the left? No, as such, no. But because as I told you, it is a genicular nerve ablation is a new thing. Lot of research, no standardization is there. There are few people who are doing it in bilateral simultaneously, or they are taking a gap of 1 to 2 months and then they're doing it. The reason is they want to see in one knee whether there is a good outcome or not. Similar type of confusion was there when when TKR was started. When the TKR was started, people were thinking, okay, we should do in one knee and then wait for others. Let's see the outcome. Now, as the TKR research and is becoming more and more common, so more and more people are doing it bilateral simultaneously or not. It again depends on the experience of the interventionist. So time limit, I don't think there is any time limit. RF ablation can be tried in simultaneously. I don't think there will be any issue. We are doing nerve block simultaneously, so it can be tried. It all depends on the clinical experience of the interventionist and the outcome that he is giving. But if you are starting a new setup or doing it new to this RF ablation, definitely go slow. Try one knee first, then see the outcome, then try for the second knee. There is no harm. Okay. So no more questions. Okay, so we'll stop the recording. See you all. Whoever wishes to join the Rehab Adda is free to join on the WhatsApp group. Thank you.